Greetings from Citizen Health and the Team Academy IAPSME Connect. And today, in the series of People's Health It Matters, we have Dr. Anirban, who is a program coordinator, Anemia Mukt Bharat program, Madhya Pradesh, at the Center of Excellence, AIIMS, Bhopal. A very warm welcome to you, sir, on behalf of all the audience.
Good evening. Thank you.
We are going to talk about gender and health. So, without wasting any more time, I would like to start with my first question: that why is gender important aspect of health?
So that actually links to Anemia Mukt Bharat program also because of the beneficiaries that we have for AMB program. A major chunk is women, right? Which is a testament to how gender does influence health outcomes in at least our country. We know for a fact, for example, that women and gender minorities are more predisposed to be suffering from inequities in health access, that they're going to be suffering more from intimate partner violence, domestic violence, that they will have difficulty accessing and securing resources for their own growth and development, that they have difficulty in accessing education, for example. So, all of these are domains which influence health either directly or indirectly. So my experience with Mukt Bharat program, it's not been very long that I've been here, but prior to this, I was working as a senior resident in AIIMS Bhopal, and that gave me the opportunity to uh, go in rural and tribal areas of Raisen district of Madhya Pradesh and see how things operate there. And it has informed me that if you're a gender minority, the simple fact of the matter is that you will have more difficulty in accessing healthcare facilities and healthcare infrastructure as opposed to if you're not a gender minority. That in itself makes gender in health an important and central aspect for a major part of the population.
Okay, and when we have always focused on maternal and child health as an important component, why should gender and health be regarded as a special component?
Because mother or like when we focus on maternal child health only, we reduce women to a diet and we reduce their identity to that of being a mother with respect to a child. Um, Now that we are moving out of the paradigm, we are looking at women of reproductive age group. But again, there also women are reduced to being able to reproduce. um, so we have to expand that definition further on. We look at adolescent girls, we look at women even if they're not reproducing, so geriatric women. We look at transitioning women, so trans women, for example. We look at other gender minorities like trans men or gender non-binary individuals or gender fluid individuals. And the one thing that is common for all of these genders is that as compared to men, they are at a disadvantage when it comes to accessing health, when it comes to health outcomes. Therefore, even though we have always focused on maternal child health as a developing country, that has been our primary agenda of public health, maternal child health. But now we have to look beyond that because the realities are different and we have to adjust ourselves to those realities.
How does intersectionality inform healthcare competencies?
So as I was speaking right now, I spoke of women, I spoke of adolescent girls, I spoke of trans men, trans women, I spoke of non-binary gender identities or gender fluid identities. Um, what intersectionality tells us is that um, various identities exist at the intersections of various levels of oppression or privilege, right? For example, a rich woman in a rural setting will be disadvantaged when compared to a poor woman in an urban setting when it comes to accessing healthcare, right? If I'm a poor woman, I live in a slum, and there's a primary healthcare center in the slum, which is like 500 meters away, I can walk down. I live in a village, I'm very rich, there's a PHC 5 kilometers away, I really cannot walk down. I need the help of a vehicle, which I might not be able to access if I'm living in the more conservative parts of the country. I'll have to take the help of a male family member, right? But compared to me, who is a rich rural woman, the capacity of a poor rural woman to access these facilities is even worse. And if I am an upper caste rural woman, then my chances of securing access to these facilities would be better than that of a lower caste woman, which might be better than a tribal woman. Then there is the intersectionality of being disabled. A disabled woman would not have the same chances as an able-bodied woman. Queer individuals might not be able to access the health facilities that they desire and deserve as compared to non-queer individuals. So if I'm a trans woman, for example, if I have not sexually transitioned, if I have not had the reassignment surgery, even though I identify as a woman, I'll be kept in the male ward. So I'll be obviously very uncomfortable because of gender dysphoria, and I'll be at a higher risk of being exposed to various kinds of harassment. So when we speak of medical competencies, we speak of competencies which are able to provide a level of comfort to our clientele, which are the patients. Um, so if we are not able to inform our competencies with the help of intersectionality or the intersectional lens, we miss out on these nuances. We end up lumping people into larger and larger brackets that does not lead to the kind of outcome we would anticipate if we treat someone. Um, there'd be lack of compliance, for example. There'd be dropouts. There'd be loss to follow up because we'll not be able to adjust for the realities that these various people are negotiating with when they're trying to secure access to healthcare services. Um, One of the examples of us actually taking into consideration this approach is the fact that Ashas Anganwadi workers are females. Since they are females, so therefore their clientele being female and children are able to much more easily approach them as opposed to males, right? In urban areas, we have Mahila Arogya Samitis, which are able to inform the working of the hospitals as they mostly cater to women and children. So these are small examples of how we already have that in us. All that we need to do is, to be very honest, listen with an open mind and reflexively adjust the way we approach these individuals so that we are able to come at a common ground where they are able to access the best treatment that they can, and we are able to provide the best that we can in terms of treatment or interventions.
So, as a doctor, sir, if I search for any remedy, what you suggest that as a people, as a society, what we can do to improve the health of this gender, or we can say that what to do to improve health of the woman, especially.
As doctors, the one thing I have seen in me also, obviously, why blame other doctors? The one thing I've seen in me also, and something I'm trying to unlearn over time, is the capacity of not being able to listen. We go with obviously presumptions or assumptions are not formed in vacuum. They're informed by previous experiences. The entire effort of a human being or as a doctor, for me at least, or for doctors as a whole, should be to unlearn the presumptions that we have made a, over our practice and approach every client with an open mind. It might not always be so that the client is recalcitrant or the client is unable to show high compliance simply because they don't want to. In most cases they are unable to be compliant because they cannot. Because let's face it, no one कोई अस्पताल घूमने नहीं आता है. तो अगर मेरे पास पेशेंट आ रहा है, that would mean that they really need something. And if I am I am addressing that and they are not coming back even after that, that means that there is something where we are losing connect, losing touch. So if we just listen, then we'll know exactly where we are unable to meet. If we listen, we can actually find a common ground. One very simple example that's from Anemia Mukt Bharat program only. When we meet pregnant women, we tell them, you know, anemia हो सकता है तो गुड़ खाइए, चने खाइए, पालक खाइए, etc etc etc. and they say ha 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 ha, and at the end of it all, you just tell them मैंने क्या क्या बताया repeat कीजिए. They won't be able to repeat, because saying ha 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 is the best way for them to get the tablets and get going. Or you ask them, do you like chana? Chana pasand hai? They'll say no. So then when I said chane khaiye, aapne हाँ क्यों बोला? So that does happen. What ends up happening is you give them IFA, they take the IFA tablets, they develop gastritis, they don't tell anyone, they throw the tablets away, they have moderate severe anemia, they have adverse pregnancy outcomes. So this entire chain of events would have been avoided if we had been able to establish a rapport with them in the at the beginning, at the very beginning. Um, Another issue which again we doctors, especially in the urban circles, can try to practice is if we are coming across people who are gender fluid, then we can ask them their pronouns instead of looking at the name, assuming that they have to be men, even if they are uh, gender expressing as females, as women, we call them by him, his pronouns. That would make them uncomfortable. So the best thing that we can do is listen to them. That is the only way we can ensure that gender in health, uh, the issue of gender in health becomes a non-issue. Once we start addressing these issues, they will eventually be ameliorated and they become a non-issue. Then we can look at other issues which also cause disparity in health access.
Okay, in the last few minutes, any message to the society, sir?
To the society, be compassionate, man. that is, that's it. Just be compassionate. It's again, as I said before, कोई अस्पताल घूमने नहीं आता. So if there's someone who has come to the hospital, just be compassionate. I'm not asking you to, like, sit till 5 if your work hour is till 1. But if you're going to sit there till 1, please sit there till 1. That's about it. That's about it. I cannot address the society. I don't think I have the capacity or the platform through which I can, but I can request the members of the society to uh, be compassionate. That's it. That's it. Nothing else.
So sweet of you, sir. Thank you so much for having talked with us. We come to know about this thing today, and I hope कि अब से अगली बार से जब भी कोई जाएगा तो अगर किसी ने भी ये वीडियो देखा तो they will get aware कि yes, we have to be compassionate for towards the patient, and that rest everything is spoken by you in the video today. Thank you so much, sir, for having talked with us.
Thank you, ma'am. Thank you so much.